This is Dr. Argozlu again from Healthy Sleep Care. Today, as promised, I'm going to discuss medications used to aid sleep. These medications can be used as to aid falling asleep or to stay asleep. It's a very common scenario and the most common consultation request I receive. The most frequent consult is obviously why this patient is unable to fall or stay asleep. And the second most common consultation I get is why this patient is unable to wake up fully and stay drowsy in the daytime. The concentration of this video is the first question. That is why somebody cannot fall or stay asleep. Obviously, the most important question behind this is what can be done for this patient and how we can help the patient. Let me share an extreme example that came to my mind from many years ago. I remember an 89-year-old woman with multiple medical conditions and multiple medications, including mirtazapine, Ativan, and other substance, was living in a nursing home and was referred to the emergency room of the hospital by the night nurse. It was early morning and the staff were unable to wake her up and she was drowsy. After a thorough evaluation, it turned out that excessive medication, particularly as-needed medication, were causing the issue. However, her workup included lab work, CT scan, and a lumbar puncture, also a neurology consultation early in the morning that was clearly invasive and unnecessary for the patient and could be avoided. So, this video will be offered as a two-part series. In the first video, I will explain principles of treatment of insomnia with medication, and in the second video, I will discuss individual medications and medication groups that can be used. The scope of these videos are for general population, and I will try to avoid technical terms as much as possible. I want to remind the listener that only 10% of insomnia patients take medication for insomnia. And that means 90% of people who have insomnia do not need medication or do not want medication. So just because somebody feels that they can't sleep, it doesn't mean automatically that they have to take medication for it. It needs professional evaluation and to look into the cause and to severity of the symptoms and combination of other factors or conditions that contributed into insomnia, so the doctor can decide if medication is appropriate or not. Regardless, we have to be aware that a very large sleeping pill market is out there, and the role of advertising is huge, and they create a demand for patient population and a feeling that the sleeping medication is needed in some scenarios that is not. Obviously, there are many patients that benefit and need a sleeping aid. In general, treating the sleep problems with medication should be avoided. Instead, we focus on addressing the sleep hygiene that in the last video I explained in details, and I really recommend you to take a look at those points. Additionally, we want to address performance anxiety related to falling asleep. This occurs when we get annoyed due to frequent inability to sleep when desired. We feel that the lack of sleep can interfere with our daily task. Because of this, we begin to get sleep anxiety, contributing to a positive feedback loop where we can't sleep as we are anxious. So this is a depiction of the positive feedback loop. The anxiety causes more insomnia, and because of insomnia we get more angry and more anxious, and we get more anxiety, and it kept going back and back and back, and we can never get to sleep. Thirdly, we also want to make sleep regular. Irregular sleep and waking times can mess with our hormonal balance and worsen insomnia and daytime sleepiness. Also, our out of sync sleep cycle can be perceived as insomnia itself. Humans are creatures of habit, and our bodies are tuned to sleep and wake up at specific times. Disruption to this natural rhythm can lead into insomnia-like symptoms. Factors such as alcohol use, over-the-counter medications should be assessed. As I mentioned in the introductory case, the patient and physician have to be cognizant of the patient medication list. And if there is drowsiness or insomnia, this list must be changed and addressed appropriately. For some patients, the use of sleep medication might be necessary, but we want to consider short-term usage to avoid tolerance, dependency, and decreased efficacy. As you use these medications over time, they lose their effect on your body. Something happens, I'm trying to avoid the technical terms, but it's called receptor down-regulation. So the same dose of the same medication does not have the same effect after a while. These complications frequently occur with long-term sleep medication usage. What happens is that after a while, the medicine that was working will stop. From here, there are two options: increasing the dose or changing the medicine, and both of them are bad, and within a few years, nothing will help the patient to fall asleep. However, combining medication with something called CBTI, or cognitive behavioral therapy for insomnia, that is a specialized form of talk therapy, is often more effective in promoting long-lasting improvements. In CBTI, we work to change the beliefs of the patient that are inappropriate and not helping with their sleep. For example, somebody says, I must have 8 hours of sleep, or if this happens, I'm not going to fall asleep anymore. And also the behaviors of the patient, for example, waking up from the sleep time, so that changes occur and outcomes improve. Purely relying on medication is not effective, but if you use it as a crutch before the CBTI kicks in to change bad habits and behaviors, then you can get long-lasting outcomes that have been proven by study after study to be effective and in most cases satisfactory. Obviously, long-term treatments are fitting for certain group of people, but usually we want to avoid giving medication for long-term to general population. Patient factors such as mental health issues, substance abuse disorder, including alcohol and other substances, while selecting the medication should be looked into. Okay, my art director, designer, person want to add this one more slide, only you can make the CBTI work. Thanks. Scientists classify sleep in different stages. The repeating pattern of wake, REM, and non-REM sleep is called the sleep architecture. In non-REM sleep, the brain waves are synchronized among many other functions that are occurring in this stage. Nerve cells maintain and repair themselves. In REM sleep, the signal becomes desynchronized, and it is when we dream most. The brain starts to think and perceive once again. I am overgeneralizing, but it satisfies the scope of today's discussion. When considering a sleep medication, we should prioritize those that do not significantly alter this sleep architecture. REM and non-REM sleep cycles play crucial roles in memory processing, emotions, and dreaming. An ideal sleep medication should not negatively impact these cycles. Additionally, we seek medications that do not cause next day drowsiness. Also, we don't want any dependency toward the chemical that would be the sleeping pill, and no withdrawal symptoms. That means when we discontinue the medication we feel bad. We want to avoid medications that cause memory dysfunction, and we also want to avoid medications that cause anxiety. Think of exercise. If for a second you look at how exercise affects our body, it has all of the characteristics of a sleeping aid. It enhances the sleep without causing the sleeping side effects, next day effects, tolerance, or withdrawal issues. The only issue is that it is a weak aid and has a small effect size. However, it is worthy of being mentioned. I would also like to emphasize that the research shows timing is essential, as exercising too close to the bedtime might disrupt the sleep. The jury is still out and more research is coming out, but personally working out late really messes up my own sleep, so I always say it is the best thing to exercise when the sun is still out. Am I good to go? Okay. Now let's talk about what an ideal sleep medication should be and do, and how individual medications can affect your night and day. For medication to be optimized, it should have a rapid onset, provide sufficient sleep deprivation, and have a minimal next day effect. We aim to maintain a stable blood concentration, ensuring effectiveness throughout the night and avoiding residual effect during the day. It is crucial to research and consult with healthcare professionals before choosing a specific medication. Avoid relying solely on advertisement and online information, please. So let's say this is your night, this is the previous day, and this is the coming one. You want medication to kick in really fast, stay on all night with you, and suddenly drops out of your system when you want to wake up. But this is an ideal and unrealistic. So you can have a medication similar to A here, which goes in and out fast. but for the second half of the night you're not covered with medication and you're relying solely on your body systems. Medication B kicks in slow but also stay in the morning. You end up sleepy throughout the rest of the next morning till it kicks out. However, it might be appropriate for some people. As shown, it can cause daytime sleepiness. Medication C doesn't get absorbed fast, but it has certain metabolites, so it kicks in a second time in the early morning when you want to stay asleep. As shown, it can cause some daytime sleepiness, but it might be appropriate for some patients. Medication D, however, is a designer medication that kicks in fast, stays steady level until early morning or late midnight, middle of the night, and comes out of your body right before you wake up. In different clinical scenarios, they each might be chosen as the best option for a specific patient. As they say, there is no one-size-fits-all approach. And it's true for sleeping aids as well. Let's talk about another issue here over this different consecutive nights. When we take a medicine, it peaks in a certain concentration in the blood and drops in after a few hours, which would be our day. The next night, it peaks at a higher concentration and peaks higher trough on the next day. This pattern continues throughout several nights until it relatively stays at a stable blood concentration. For example, in an antibiotic or heart medication, we might love this effect, but that is not a wanted character for a sleeping medication. We want this sleep medication to get out of your system so it really doesn't have an effect size in the daytime. We do not like only having some effect in the daytime, and we would like a medication that gets out of the system and the nervous system and the blood as much as possible during the daytime. These factors create different groups of medication. Short-acting or fast-acting, ultra-short-acting medication with extended effect. And also medicines that have early morning effect or next day effect. For example, for a patient with severe anxiety, they might want to use a medicine that has some next day effect to allow some level of sedation in the second day. In the next slide, we will discuss individual medication groups that can be used. So let's turn the page here. So the first group of medication that I want to talk about is barbiturate. This is a very old group, and still some of these medications like phenobarb are used for seizure disorder, but almost nobody uses them for sleep anymore. The second group of medications are benzodiazepines. Benzodiazepines like Ativan or Xanax or Klonopin, or there is a lot of different benzodiazepine that is used. They have different half-life, they have different length of effect, different fastness in initiation of effect. These are serious, hardcore medication that are used for severe anxiety, and also in this day and age, doctors don't like to use them for just the purpose of sleeping. One medication that I like to mention is Xanax. Xanax is very, very fast acting and is very high on addiction liability, so be careful with that medication if you use it. The next group of medication that is very commonly used now is benzodiazepine receptor agonists. They work like the benzodiazepines and they attach to the same receptor inside the brain. However, they don't cause the type of addiction that we can see with benzodiazepines, or dependency, even not addiction. The most commonly used medication in this group is Ambien. They have options of Ambien CR or Ambien ER. The other one is Sonata, that is also ultra fast acting, and it's good to get you to sleep. Medication like Lunesta, for example, is another one in this group. This is the bread and butter of current sleep medication use. The next group is melatonin. Melatonin is a molecule that is innate to the body. It helps with the circadian cycle and regulating the day and night cycles. It gets secreted inside the body around 2 hours or 1.5 hours before the expected sleep time. So in case you want to use melatonin for the purpose of getting to sleep, you need to use it around 2 hours before your sleep time. One caveat is that it has to be used as a low dose, 3 to 5 milligram. High doses will have some hypnotic effect, but really overdrive the circadian rhythm and they will backfire. The next group of medication are tricyclics like doxepin and amitriptyline, or the old brand name was Elavil. These medications have a side effect of sedation. They are depression medications, and they are also good for initiating and maintaining a sleep in appropriate patient. Next group is called orexin antagonist. Orexin is a chemical inside the brain that helps with making you stay awake. So if we antagonize that, if we oppose that, then the sleep happens. Orexin cells inside the brain have a lot of connection to different places that orchestrate the sleep, and Belsomra is the most common medicine in this group. This is a good medication for not messing up with the opioid or benzodiazepine or alcohol receptors, so keep that in mind. I use it quite often. The two commonly used medications specifically for elderly are trazodone or mirtazapine. They have good side effect profiles. They have complex receptor activity patterns, so I'm not gonna talk about them here. Trazodone used to be the most commonly sleep medication used in the world, and mirtazapine, because of the fact that we have some availability to use it in people with hepatic or kidney impairment, elderly people, is a choice for elderly. It will get you to sleep, there is no question about that. The problem is the next day effect. Sometimes it becomes hard to wake the patient up from it. And as a last note, antipsychotic and anti-seizure medications can be used with the side effect of sleepiness in mind. For example, if somebody is psychotic, or somebody needs a second kick medication for depression, you can think about Seroquel. Seroquel is also pretty widely used, and it does cause sedation. So in an appropriate patient, we can get help, the sedative help, from this kind of medication as well. Paxil, Zoloft, and Lexapro are the depression medication in group of SSRI. that cause more sleepiness, and they are very commonly used in patients with anxiety and depression. And if we want a side effect of sleepiness, we can use these groups, and taking it at night will help you with the sleep. This concludes the part 1 of my discussion. In the next video, we will get into each of these medications in more detail and discuss how they work, who's appropriate, who's not appropriate, and why. Again, at the end of my talk, I want to appreciate you listening to the information that was provided, and also remind you to use this as a blueprint, and for sure discuss with your doctor about appropriateness of any decision about medication that you want to make. And again, reemphasize the cognitive behavioral therapy for insomnia that will solve the problem rather than putting a band-aid like the medication. Obviously, for CBTI to work, it needs your cooperation, and one of the cognitive issues that might need to be fixed in people is that, CBTI doesn't work, which is the first wrong cognition that the CBTI helps to alleviate. And that would be the first step to fixing the root cause of your problem. Thank you so much, and I see you in the next video when I discuss the individual medications. Thank you. Bye-bye.